when we're looking at EKGs, I mean, there are a whole lot of things we can get, a whole lot of information we can get from EKGs. You can find out about rate and rhythms and axes and so forth that we've looked at this morning. You can determine evidence of pre-excitation syndromes and underlying cardiomyopathies like hypertrophic cardiomyopathies and congenital type heart disease. But day in and day out, when we order an EKG, we're looking for what?
Ischemia.
Yeah, we look, well, not necessarily just ischemia. We're looking for evidence of underlying coronary disease. So let's just take a moment at the beginning before we start through the process of looking at what it is on the EKG we're going to pick apart, and just first try to see as an overview what are those things that represent evidence on the EKG of underlying coronary disease. Okay, ischemia is one, infarction that is acute is another, infarction that is old is another. We said earlier QT prolongation is another. So if we write those on the board, what are they? They are ST elevation, ST depression, Q waves, and y'all don't have to write this down. Remember, it's all in that paper, so all you do is just listen. I'm going to say the same thing over and over and over and over, so that by the end of the month, you're going to know the answers. But at least for now, I want you to just kind of focus in on the details as we go through them. So the T-wave axis, those are examples of changes on the EKG that we're going to look at on every EKG we pick up that can represent evidence of underlying coronary disease. Okay, so as you know from the summary paper, there are multiple things, in fact there are several here, that can cause each of these, including Q waves and T wave axis changes, and we'll come back to those in some detail in a little bit. But first, let's start with the beginning, and that is the thing that I asked y'all to do first today, and that is to measure the intervals, determine the rate, and determine the rhythm. Now, we're going to pick up rhythm as we just simply go through the EKGs, and by the time we finish, you will have seen the vast majority of the rhythm problems, other than the tachycardias, and we're going to talk about them in great length as well. So first, let's take the intervals. What is the PR interval? Where does it begin? Where does it end?
Begins at the beginning of the
P wave and ends at the
end of the R wave.
No.
Peak of the R wave.
It begins at the beginning of the P wave and it ends at the beginning of the Q wave. Why do they call it a PR interval? Well, it's a bit of a misnomer, but that's correct. That's what it should be. Now, should there be a Q wave in limb lead 2, which is typically where we look to determine the PR interval? No, usually not one there. So there's usually an R wave, hence the term PR interval. So you measure the PR interval by measuring from the beginning of the P wave to the beginning of P wave. However, had there been a Q wave, you would have measured the PR interval from the beginning of the P wave, there, to the beginning of the Q wave. In other words, you measure the PR interval from the beginning of the P wave to the beginning of the QRS, whatever makes up the beginning of the QRS. Now, how many milliseconds should that distance be in time?
0.06.
I'm sorry?
About 0.06
Yeah.
seconds.
Well, not 0.6. 0.16 would be about the middle of the normal PR interval. So in other words, we're going to start with somewhere in the neighborhood of about 120 milliseconds to 200 milliseconds. Now let's think about the EKG paper for a moment. You have these dark red lines that make up the grid. And then in between that are the very fine red lines that are smaller. Okay? The distance from here to here, the distance of one of the tiny blocks on the EKG paper is how many milliseconds?
0.04.
0.04 seconds or 40 milliseconds. So you could have said this 0.12 seconds or 120 milliseconds. So you just simply need to go one or the other. Doesn't matter which way you learn it. I learned it in seconds, but basically most of the literature is written in milliseconds. So I'll just give you those numbers to work through it. So if one of these little blocks is 40 milliseconds, how many of these little blocks is a whole large block? It's 5 times 4 is 200 milliseconds. So if you wanted to look at the PR interval against this background grid, what would be, how many little blocks would be the range for a PR interval?
3,
4 into 12 is 3. So 3 little blocks to 5 little blocks. That gives you the range. Now, what do we call it when the PR interval is more than 200 milliseconds? Not everybody at once. Y'all know this.
What's
The first degree AV block. Okay, first degree AV block. All right. Now, what do we call it when the PR interval is less than 120 milliseconds? Kind of a typical board question. What is one word in a 5-choice, multiple choice question that would get you the answer to that?
rapid?
We refer to those as pre-excitation syndromes. Name me a few.
Wolf, Parkinson.
Yeah, Wolff-Parkinson-White, probably the most common, at least in this geographic area. Lowndes-Ganon-Levine, LGL syndrome. Brugada's syndrome. Brugada's actually usually does not have a short PR interval, but it has other features of like reentrant tachycardia that are common to LGL and Wolff-Parkinson-White. But those early reentrant tachycardia syndromes are the ones that are associated typically with a short PR interval. So if you see a short PR interval, a PR that is less than 120 milliseconds, less than 3 little blocks wide, and a delta wave, then you have Wolff-Parkinson-White. But if you see the same short PR interval and no conduction defect, no delta wave, then you have Lowndes-Ganon-Levine syndrome, LGL syndrome. That's how you tell them apart. Okay? I've read something over 200,000 EKGs in 30 plus years. I saw my first Brugadas with the students last week. It is rare, at least in this area. It seems to be indigenous in some of the Japanese population and the Italian population. So if you were in one of those parts of America that had a lot of those, wherever you guys end up training, you may see a lot of Brugadas. Some of the literature suggests it's a very common pre-excitation syndrome, but I've never seen a single case. It's that one that I saw last week, and that was just the EKG, and the patient was in the hospital for something else. They didn't have syncope or presyncope or any of the usual symptoms you might associate with it. Okay, so you got that? That's the normal PR interval. Now, while we're here, and I've used the term first degree AV block, let's go ahead through the AV blocks so we cover them. There is first degree AV block, and that is defined as a PR interval that's greater than 200 milliseconds. Okay, what is a second degree AV block? Well, there are two types. Mobitz type 1 Mobitz type 2. 1 and 2. So Mobitz type 1 AV block is that pattern where the PR interval typically starts out normal, less than 200 milliseconds. And then with the next beat, it'll be longer. It'll be longer. And then by the time the third beat comes along, it's so long that P wave just occurs and there's no QRS. So you have a normal P wave, normal PR interval, longer PR interval, and then just a P wave by itself, meaning that the PR interval was so long that it just simply never conducted through the AV node. And that pattern is called Mobitz type 1 second degree AV block. There's another name for that. Y'all remember it? AV Winky block. It's one and the same. Okay? AV Winky block and Mobitz type 1 second degree AV block are one and the same. Now, what is Mobitz type 2 second degree AV block? You can get used to that. Yes, Mo. What is that?
Is that where every other P wave gets conducted through?
Every other
P wave ends up having a QRS complex behind it?
Yeah, that's right. In other words, every other beat conducts through the AV junction, and that means that every other beats don't conduct. So you'll have a normal PR interval, and then a P wave with just a pause following it and no QRS complex, and then another normal PR and a QRS, and then nothing, just a P wave. So basically you'll have a string of P waves across the ECG strip. And for every P wave, for every 2 P waves, there will be 1 QRS complex. And that's the most common type of 2-to-1 Mobitz type 2 second degree AV block. And why don't we distinguish between those two? It is because that Mobitz type 1 second degree AV block has a tendency clinically to just settle down and not progress on to third degree AV block and require pacing, electronic interventional pacing. Whereas Mobitz type 2 second degree AV block has a tendency to progress on to third degree AV block and require interventional pacing of some sort. So clinically it's important to recognize those two, because one of them you sit on and watch and sometimes have to put in a pacemaker, Mobitz type 1 second degree, and the other one will more likely proceed. In fact, you generally just go ahead and put in a permanent pacemaker in most of those situations. Okay, so you got 3 types of AV block. We've covered now 2 of them. The other one's third degree. Third degree AV block is just simply that, meaning it is complete AV block. You have complete AV dissociation. You will see a row of P waves across the EKG paper and a row of QRS complexes, and they won't have any relation to each other. The PR interval will just march in and out of the QRS. Some of the PR intervals will be that long, some of them will be that long, some of them will be that long, and everything in between. So if you can look at the strip long enough, you'll just simply see P waves interspersed equally with the same P to P interval and the same R to R interval, but the two are unrelated to each other. The PR will vary, in other words, from beat to beat. Okay? So third degree AV block requires interventional pacing most of the time. What are the escape mechanisms that you see as these degrees of AV block progress? What's the normal, if we gave you some kind of poison like digitalis and completely blocked your AV node, how would that progress?
Your heart will begin pacing somewhere.
Where?
Downstream of where?
Where? At the AV junction, okay? it would just pick up right there, just up at the top of the His bundle, well before you went into the bundle branches, and so the QRS would look normal. And so you'd have these an escape junctional paced rhythm. Okay, and when you see that, you know then that you likely have an escape pacemaker where the heart's taking over normally at a slower rate. What rate? In other words, when do you see escape junctional rhythms? At what rate range?
60 to 80.
And a lot slower. Normal is from 60 to 100, so you figure it's going to be something slower than that. And so 40 to 60. That's the typical rate at which an escape junctional mechanism will take over when you have third degree AV block. All right? Well, what if that's not the case? What's another possibility? What other kind of escape mechanism do we have that will take over if both the sinus node fails and the AV node fails?
Ventricular.
Ventricular. And what rate might it pick up at?
20 to 40.
Yeah, 20 to 30. So what's another name for an escape ventricular rhythm? An agonal rhythm. Meaning the person will stay alive for a few minutes with just an occasional. This is a code situation where you look up at the screen and there's just an occasional what looks like a PVC scattered across the screen at rates of 10 to 30, somewhere in that range. That person's about to die if you don't do something. But it is nevertheless an escape mechanism, and it'll keep them alive. Every time that ventricle contracts, for each of those beats, you get some forward blood flow. So an escape junctional pacemaker is generally very reliable. It'll keep you going, and you may not even be dizzy with it. May not even have any syncopal episodes. But if you get to if you get to a ventricular escape mechanism, you're going to hit the floor. Once you go into that kind of, quote, agonal rhythm, you won't have enough cardiac output to generate a blood pressure. You'll have no pressure to the brain, and you'll hit the floor in a matter of a second or a few seconds. Okay? So that is how we look at AV blocks. So with a PR interval being 120 to 200, let's review that again. When the PR interval is less than 120 milliseconds, 3 little blocks, pre-excitation syndrome. Lowndes, Gannon, Levine, Wolf, Parkinson, White. Okay. And when it's longer than 200 milliseconds, some kind of AV block. First degree AV block, second degree AV block, third degree AV block, in those patterns we talked about. All right. What about the QRS? What's the range for normal for a QRS in milliseconds? From how many little blocks to how many little blocks? Basically from about 1 to 2. Okay, so let's just say a little more than 1. Let's say 50 to 90 milliseconds. Now, how many little blocks is 1? How many milliseconds is 1 little block?
40.
40. How many is 2? 80. Okay, so you see that if you just simply look at the QRS against this background grid of these little blocks, basically the thing ought to be pretty close to 2 little blocks wide. It might be a little short and be 70 milliseconds. It might be a little long and be 85 or 90 milliseconds, but basically it's going to fall in that range if it is normal. But what if it is not normal? There are, what do we call that? If the QRS duration is longer than 90 milliseconds, what do we call that?
Conduction defect.
We call it a conduction defect. What are the 3 types of conduction defects?
Left bundle branch
Left
block.
bundle branch block.
Right bundle branch
Right
block.
bundle branch block. Right. That's not a hard guess. And the other one
Non-specific.
is everything else. A non-specific intraventricular conduction defect. N-I-V-C-D. Non-specific intraventricular conduction defect. Okay? And this is a wastebasket term for the most part. There are incomplete right bundle branch blocks, incomplete left bundle branch block, delta waves, intrinsicoid deflection like you see with LVH. There are a whole bunch of different kinds of, or reasons that you may get a minor conduction defect. In other words, a conduction defect that is, say, between 90 and 120 milliseconds. So what do we call those? Those are the three names, and the range is from 90 to 120, or if you want to be really picky about it, 110. In other words, once you get to 120 milliseconds, you're in the range then that you can have a bundle branch block. So this, I'm writing them wrong. This is 90 to 110, okay? And these two are anything greater than or equal to 120 milliseconds. Okay? That make sense? Which lead would you go to measure the PR interval? I told you earlier. Limb lead 2. All right, there's a reason for that. We're going to see that in a minute. What lead would you go to measure the QRS duration? Any of them, but it turns out that you can usually see it the best in V2. Okay, and the QT interval. Which lead would you go to measure the QT interval? Well, again, it turns out just by pure chance, you can look at any of them, and you should look at any of them, but V5 turns out to be the one that's the easiest to see. Now, how are the EKG leads laid out? 1, 2, 3, R, L, F, V1, V2, V3, V4, V5, V6. So when you start through to measure the intervals, okay, go to limb lead 2 for the PR interval, skip AVL, go to V2 to measure the QRS, V5 to measure the QT interval. Just an easy way to remember. You just come straight across the paper, but skip AVL. All right? Now, the QT interval. How long should the QT interval be?
Less than 0.4.
Less than
0.45.
0.4, that's right, yeah. So basically, for a rate of precisely 60, okay, not 80, not 40, not 130, but just 60. For a rate of 60, for a male, that is an adult. Okay, in other words, the QT turns out to be the QTC, the QT corrected. It actually must be corrected for gender and for age and for rate. You can't keep that in your mind generally. So when we read EKGs, we have this little grid on the wall where we dictate that has all this information on it: male, female, age, and on the other axis is the QT itself against the rate. So you can say, okay, I got a QT of 0.46, and I come down here down to a rate of 40. That's okay. But if you had the same QT of 0.46 and you looked over here and your rate was 80, that's long. That would be a prolonged QTC. So you have to kind of begin to think of the QT interval as being a moving target, moving primarily with the rate. And we'll talk about that a lot more. But basically the QT for the rate of 60 should be less than or equal to 440 milliseconds. So how many blocks is that?
It's about 2.
Well, it's 2 big blocks and then 1 small block. Well, and so if the QT is less than that, if it's 0.35, 0.37, 0.41, 370, 380, 390, 400, 410, 420. If it's any of those numbers, you're okay. But if it gets longer than 440 milliseconds, then you have prolonged QT interval. So that's how you measure it. Now, how do we measure the QRS? Let's come back up here for a second. I asked you where the PR interval, and we said is from the beginning of the P wave to the beginning of whatever starts the complex. The QRS is measured the same way. It's measured from the beginning of whatever starts the QRS complex, whether it be a Q wave or an R wave, to
The end of that S.
the end of, what do you call that? What do you call the end of the QRS complex? It has a name.
J point.
You call the J point. So how do you tell where the J point is? And you will see a lot of EKGs where you just see this transition, where it just sort of transitions into the SD segment, and you really don't know where along this path the J point is. But in most of them, you can see this place where the QRS complex will go up, and it'll go right up to a point, and then it'll change direction slightly. That's the J point. Okay? So the QRS measurement is from the beginning of the Q wave or R wave to the J point. That gives you the measurement. And the range, 50, slightly over 1 little block wide, to slightly over 2 blocks wide. And that's how you measure it. Okay? We got that?
Yes, sir.
Sure? All right, got it. All right, we're going to change directions now and start to the real meat of the matter, and that is to actually look at some of the EKG changes. That's how you measure it. How you measure the rate. We didn't talk about that. How do you determine the rate on an EKG?
You can count the number of beats in a 10-second strip and multiply it times 6.
6, exactly. Because the EKG itself is 10 seconds long. 10 into 60 seconds will be 6. So you just simply count the number of QRS complexes across the 10-second EKG strip and multiply it by 6. And you can do that whether the rhythm is regular or irregular. But otherwise, you can take this background grid, the big blocks, and measure 3 of those blocks. If the R to R is 3 of those blocks, the rate is 100. Okay? If it's 2 of those blocks, it's 150. If it's 1 of those blocks, it's 300. So 300, 150, 100, and then it drops to 75 from there. 300, 150, 100, 75, 60, 50. And that, as long as the rhythm is fairly regular, you can get a pretty good guesstimate of what the rate is based upon that just quick view. And back to the QT interval, it turns out that in rates rates greater than 100, all tachycardias, if the QT interval is more than halfway across the R to R interval, you have QT prolongation. Just an easy rule of thumb way to remember. Okay? Now let's look at some of the real changes. Probably the most common change on the EKG that we look for to tell us that there might be evidence of underlying coronary artery disease is to actually measure the QRS and the T-wave axis. So let's take those one at a time. We'll take the QRS axis first and let's measure it. Now, what do I mean by a QRS axis? Well, you remember a vector, hence the term vector cardiography. You remember your vectors from college physics, where a vector is a force that has both direction and amplitude of some kind. In this case, it's direction and voltage, or millivolts. Okay? So let's take a person laying on the table, face up, right hand off that side, left hand off this side, feet towards west. Where's the heart? Let's do it this way. You take an ice pick and put it in his AV junction. Show me where you'd stick it. Brett, you're the first student in 6 months that has got that right. Most of the students want to stick just off to the left of the rib cage, or off to the side of the sternum. And you completely miss the heart there. You go to the lateral edge of the left atrium, you go under the pulmonary artery, you go under the arch of the aorta, you go over the left ventricular apex. You completely miss the heart. The heart is literally in the middle of the chest. Okay, how do you know that intuitively? Because if it were not, when you do CPR and you press the sternum against the front of the spine, if the heart were not lying directly between the two, you couldn't make CPR work. You'd just be pushing the heart back into the soft, spongy lung tissue, and you would get no ventricular compression. That's how you know that it works. Okay, so with that in mind, where are the leads? Down here. Well, let's think about it this way. Let's just say this is like a football game, and this is the playing field that the person is laying on. You have some people that are watching the game. How many people watching the game? 12. And 12 leads. Just think of those as 12 people. You have some people sitting at the ground level on the 50-yard line watching the pass being thrown across this way. So they see the event as coming like this. What about the person in the end zone? Well, they don't see it that way at all. They see the ball coming at them like this, head on. The people in the other end zone see the ball going away from them. So think of these 12 leads of the EKG as like being 12 spectators, all watching precisely the same event. What is the event? Okay, let's transpose this up here. Okay, we're going to transpose the playing field to the board, and we're going to draw a circle. Okay, and then we're going to arbitrarily attach a given number of degrees to this circle, starting with 0, which is arbitrarily there. Where is that relative to the person's left arm? Okay, it's out here. It's this. So this person is off to this side. So how is the heart in the chest? It's in the middle. But how is it pointed? Remember, the heart is an elongated structure. It's in the middle, but it's elongated like this. So where does depolarization, where does this vector begin? Where does depolarization of the heart begin? In the sinus node, which is in the roof of the right atrium. Okay, so it's way up here. And where does it propagate to from there? Well, initially, it propagates just as though you had thrown a pebble in a pond. It comes out concentrically from the little cluster of cells. How big is the sinus node? Can you see it if you had it in your hand? No. It's a microscopic cluster of cells that you can't really see, so it's very tiny. And the wave of depolarization of the heart muscle that comes out from the sinus node comes out concentrically. But look what happens. It starts out in all directions, but you can see that the bulk of the depolarization starts at one end of the heart and works its way through the conduction system toward the other end of the heart. All right? So you get a vector. You get a pass thrown. Some leads see that pass coming perpendicular to it. Some see the ball coming directly toward them. Others see the ball going directly away from them. And this, if you don't get anything else I say, this is the most important aspect of reading an EKG. What makes a complex be upright versus a complex that is down.
Whether it's coming toward it.
Yeah, yeah, exactly. It's where the lead is relative to this vector of depolarization of the heart muscle. So let's label this now with just a couple of the 12 leads. Okay, let's label it limb lead 1 and limb lead 2. Now, how do you suppose on 95% of all the EKGs you're going to do for the next 40 years, what do you suppose limb lead 2, this QRS complex, is going to look like?
Upright.
It's going to be an upright deflection. If it's not, something's wrong. Your QRS axis is not normal. Okay? Well, what about limb lead 1? This vector is not going directly toward it, but it's going relatively toward it. So how do you suppose it's going to see the event? Also an upright complex. So that you can anticipate that on most people's EKGs, limb lead 1 is going to look like this. Limb lead 2 is also going to look like that. Okay? Now, what if you had a person that for whatever reason their heart was sitting in the chest off this way? Short, obese person, stubby, kyphosis, so that the heart was turned around this way and you had a left axis deviation.
Negative.
Yeah. Then what determines the direction? Well, it's the direction of the vector relative to where the lead is. So let's put the rest of these leads up here. 1, 2, 3. Okay, and then R, L, F. So F is at plus 90 degrees. 3 is at plus 130, 120 degrees, and 180 degrees, and minus 30 degrees. Okay, so if you had a vector that was off in this direction, you would expect that what would limb lead 2 look like now?
Negative.
It would be a negative deflection. All right. What if you had one where the QRS vector was exactly perpendicular? What would limb lead 2 look like in that situation?
There'd be no deflection upward or it'd be equal deflection.
Exactly. You would have some deflection. Okay. It's like if the guy threw the ball by you like this, you would see it as it went by. You would see it kind of coming toward you over here, but you'd see it going away from you over here. So limb lead 2 would typically look like that. It would be somewhat upright and somewhat down with the amount, the voltage, depending upon how much heart muscle you were depolarizing. So you see how vectors determine the direction of depolarization of the heart, or depolarization of the heart determines the vectors. All right? So you can extrapolate from that to every lead, and let's do that. But the truth is, you don't need to. Only limb leads 1 and 2 will tell you if the QRS depolarization vector falls within the normal range. What is the normal range?
Negative 30 to
Minus 30 to
120.
plus 90. Okay, minus 30 to plus 90. Okay, now look at limb lead 2. If limb lead 2 is a positive deflection, what does that tell you? That tells you that the vector is somewhere between there and there. Right? What if limb lead 1 is also an upright deflection? What does that tell you? Well, 1 is this way. That's the perpendicular to 1. So if 1 is positive, you know it's between there and there. What is the overlap between those two? Minus 30 to plus 90. Therefore, if limb leads 1 and 2 are both upright, the QRS axis must be normal. It cannot be physiologically any other way. Why does Dubin's say that's not right? Why does Dubin's use limb lead 1 and AVF? Because Dubin's assumes that the normal QRS axis is from 0 to plus 90. Okay, so it depends on what you call normal, but the neuro literature uses minus 30 to plus 90, and therefore limb leads 1 and 2 are the key leads in determining the QRS vector, or the QRS axis. All right, you got that term in your mind now? QRS axis. All right, that is a vector direction with a range for normal, minus 30 to plus 90. All right, you have that in your mind? All right, now let's wipe this clean. Same heart, same person, same playing field. Heart's in the chest like this in the middle, angled over to one side. Bring it back down. There you go. Now, where is V1 relative to the heart?
It's above it.
It's up here. It's like in the Goodyear blimp. Okay, it's got the Goodyear blimp view of the playing field. In other words, we're no longer looking at this plane where the 6 limb leads were. The 6 limb leads are kind of scattered around. They're in either of the end zones or in either of the stadiums, but down at ground level, so to speak. And the chest leads are now in this plane. They're kind of in a perpendicular plane with the Goodyear blimp view being up here where near V1 is. But my point is this: where is V1 relative to the heart? Well, it's above it, that's true. Okay, it's on the front of the chest wall. But is it directly over the heart, off to the right side, off to the left side, just below it, just above it? Because where it is placed on the chest determines what V1 is going to look like. And it turns out that by designation, you put it in the second intercostal space, off to the right of the sternum, so that V1 is above the heart and off to the right, and the heart is aimed at an angle like that. Now, with V1 up here, and the wave of depolarization starting here and propagating in this direction, what do you suppose V1 will look like?
Should be
It'll be a negative deflection. Now, come around to V6. Have you come directly across? No. They're actually turned at an angle, so that by the time you come from V1, V2, V3, V4, V5, V6, you're not only now under the turf looking up, but you're also now below the heart toward the feet with V5 and V6. So if V5 and V6 are sitting around here and the wave of depolarization is now going directly toward them,
It should be a positive deflection.
then V5 and V6 should always be upright deflections on the EKG paper. What about V3 and V4? They're in the middle. And so very frequently, very commonly, you'll see V3 and or V4 be somewhat upright and somewhat down. You'll have an R wave and an S wave component. And it'll be all over the board. Sometimes V3 will have more R wave than S wave. Sometimes V3 will have more S wave than R wave. Same way with V4. We call those transitional leads. But now let's draw that on the board. Let's take V1. It will be pretty much a downward deflection. What about V2? It may have a little taller R wave, but it's still going to be pretty much a downward deflection. What about V3? Well, it's now getting, something like that. V4. A little more R wave than S wave. What about V5?
More R wave.
More R wave. V6. Okay. Now, just focus your mind for a second on the R waves. Little teeny R wave, slightly bigger, 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 and largest. So, we have now determined the QRS axis in the limb leads, and that was in this plane, and we said that by designation, by arbitrary designation, that the range is from -30 to +90. All right. Here we have determined the R wave vector, the QRS vector, in the chest leads, but we haven't put a degrees on it. What do we call it? What do we call the QRS axis in the chest leads?
Progression.
We call it R wave progression. Hence the term R wave progression. It progresses from a little bitty R wave in the anterior chest leads to a much larger R wave in the lateral chest leads. Okay? And that's why it progresses the way it does. So, if you were going to pick two leads, pointing to V5 and V6, if you were going to pick two leads to tell you if the R wave progression was normal, not normal, V5 and V6 are the two to look at for the same reason that limb leads 1 and 2 were the two key leads to look at for determining the QRS axis in the limb leads. So, if the R wave is bigger than the S wave in V5, the R wave progression is normal in that lead. If the R wave is bigger than the S wave in V6, then the R wave progression in that lead is normal. If they are both normal, the R wave progression is normal. And if you call it based on these transitional leads, you'll end up being wrong more frequently than you're right. In other words, you'll overcall poor R wave progression. So just don't go there. Just use the R wave in V5 and V6. If they're upright, the QRS axis in the chest leads, in other words, the R wave progression, is normal. You got that? And this time, instead of talking about a QRS axis in the limb leads and a QRS axis in the chest leads, we're going to talk about a T-wave axis in the limb leads and a T-wave axis in the chest leads. All right? Same circle, same heart, same everything else, except this time the heart muscle is not depolarizing. But what is the T-wave on the EKG? What does it represent?
Repolarizing.
It represents repolarization. So how does the muscle of the heart repolarize if it depolarizes starting here and goes in this direction?
It'll repolarize in the same.
Exactly, the same direction. So if this was the first heart muscle to depolarize, this will be the first heart muscle to repolarize. So you will see that wave of depolarization take exactly the same direction that the QRS depolarization vector took. And yet here we're looking at repolarization. In other words, we're looking at the T-wave axis. What do you suppose might be a normal range for the T-wave axis? How about the same? -30 to +9. Okay? And for all the same reasons. So instead of wading back through all that, let's jump immediately to V5 and V6. In other words, if you wanted to determine what the T-wave axis in the chest lead should be, you would look at the T-waves in V5 and V6. And what should they be?
Should be positive.
They should be upright, so that you should have an upright QRS and an upright T-wave in V5 and in V6. Now, let's take, this is V5 and V6 looks like limb leads 1 and 2. The T wave is upright in all those leads. What if the T wave in V5 is flipped, but the T wave in all the other three leads is normal? What do we call that? Well, it's not a normal T wave axis, it's an abnormal T wave axis. But there's another term we attach to that. Non-specific T wave changes. All right. What if both that one and that one were flipped? What do we call that? Non-specific T wave changes. In other words, if one of these 4 leads is flipped, 2 of the 4 leads is flipped, 3 of the 4 leads are flipped, or if all 4 of the 4 leads are flipped, we refer to all those T wave axis changes as non-specific T wave changes. Now, what does that mean? In other words, what does it mean to have an abnormal T wave axis? Remember now, to review, we've looked at a QRS axis in the limb leads, and we call that a QRS axis. We've looked at a QRS axis in the chest leads, and we put the name R wave progression on that axis. We've looked at the T wave axis in the limb leads, and we call that T wave axis. We call that non-specific T wave changes if it's abnormal. We don't call it anything if it's normal T wave axis. And we've looked at the T wave axis changes in the chest leads, and we also attribute that the same name to that. So when we're looking at the T wave repolarization axis, if it is not normal in any of those 4 leads, what does that mean clinically? Let's name some things that can cause T wave axis changes. Ischemia, hypokalemia, right? Hypokalemia, ischemia, hypercalcemia, hypocalcemia, hypomagnesemia, thyrotoxicosis, hypothyroidism,
Hypernatremia.
acute MI, hypernatremia, DKA, and the other metabolic acidosis for that matter. Stroke, acute MI, ischemia, what else? Chest trauma, and on and on and on. In other words, the T wave vector is 1, such a small voltage, and 2, so sensitive to factors occurring in the body that are electrophysiologic, that it just becomes so sensitive that just about anything will push that vector one way or the other outside its normal range. And so when that happens, we call it non-specific T wave changes. And so on the surface you might say, well, gee whiz, it looks like it's not useful. If that many things can be attributed to these T wave axis changes in limb leads 1 and 2 and chest leads V5 and V6, then why don't we even go to the trouble to call non-specific T wave changes? Doesn't make any sense, does it? Well, let's make some sense out of it. All right, I promise we're getting there. Now back to our ST segment elevation and ST segment depression. And I promise I'm going to come back to the T wave axis issue. All right. we said that there are at least a couple of common ST segment changes say that another way. We said there were a couple of common causes of ST segment elevation. One of those is referred to as early repolarization. Now, and the other is called injury. Now, early repolarization is a variant of normal. It is normal. Okay? And I'm going to ask this rhetorical question over and over and over with a slightly different twist to it. So pay careful attention. If I gave you 100 EKGs from patients in the emergency room who had presented with chest pain, what percentage of those EKGs would have ST segment elevation from some cause? More than half. Let's just say around 60% of them will have some ST segment elevation somewhere in the 12 leads. All right? Now let's take a subset of those ST segment elevations, and let's say that if I gave you 100 EKGs and told you that all 100 of them had ST segment elevation, what percentage of those 100 would be due to early repolarization? Any idea? I mean, you can see you have to get some idea in your mind of how common is this, so I know kind of what to attribute it to when I see it, once you learn to recognize it.
15, 25.
95% of all the ST segment elevation you're going to see is going to be due to early repolarization. When you draw a T4 level, you get that test back from the laboratory with a 95% confidence level that the number that they gave you is truly reflective of that person's thyroid status. Same number. So why don't we just say, if you see ST segment elevation on an EKG, they're all due to early repolarization. You'll be right 95% of the time. How can you lose?
5 people out of 100.
Because the other 5% is having something lethal happening. So we have to figure out a way to pick out of those 100 people with ST segment elevation on their EKG. We have to figure out some way to pick out these other 5%. Well, what are they? Well, they are acute MIs. And what is the other type of injury to the heart muscle? Pericarditis. Exactly. Okay. Now, of those, of this other 5% that's left over, what percentage of those are due to acute MIs and what percentage are due to pericarditis? That's how it breaks down. So if you have 100 people with ST segment elevation that have chest pain, only about 1% of those will have acute pericarditis. The other, but 4% of them will have acute MIs, and you've got to pick those 5% out of these 95 that are just a variant of normal. So how do you do that? Well, let's take what we just learned and turn it around. What do you suppose, if that long laundry list of things will alter the T-wave axis, what do you suppose pericarditis would do to the T-wave axis? It'll shift it. What will an acute MI do to the T-wave axis? It'll shift it. So it would be really unusual to see an acute MI with ST segment elevation that had a normal T-wave axis. Okay? So suddenly that seemingly worthless, overly sensitive T-wave axis can now be used like a D-dimer to say that if it's normal, you don't have an acute MI. The ST segment elevation you're looking at is due to early repolarization. So you can easily sort them out. Follow me? Okay. Now, with that same logic, let's look at what happens now to the ST segments that we call ST depression. What are the two most common causes of ST segment depression? If this one is injury, that's the bad part. Most of them early repolarization. We're going to use the T-wave axis to separate these two out. What about ST segment depression?
Ischemia.
Ischemia. And
Ventricular hypertrophy.
digitalis. Okay? Now, I ask the same rhetorical. So if I ask you the same rhetorical question with ST segment depression, if I gave you 100 EKGs and told you that all 100 of them had ST segment depression on them, what percentage of those ST segment depression would be due to ischemia and what percentage would be due to digitalis?
95 ischemia.
So, very different from ST segment elevation. When you see ST segment depression, the odds are it means something bad is going on. So you never ignore ST segment depression. You can ignore ST elevation and be right 95% of the time out of just sheer ignorance. Okay? But you won't get away with it if you ignore ST segment depression. So how much ST segment elevation is enough to suggest an injury current? The answer is any. Okay? But you're going to say, no, wait a minute, I thought it was 2 millimeters. Well, where does the 2 millimeters come from? It comes from the use of thrombolytic agents. Thrombolytic agents, when injected intravenously, will kill the person you're giving it to about 1 to 1.5% of the time. But we don't give it unless we're pretty doggone sure that the ST segment elevation that they have is indeed due to an injury current. So one, we don't take those injury currents with ST elevation between 0.5 millimeter and 2 millimeters. We just sort of put them aside and say odds aren't good enough. And so any ST elevation that's more than 2 millimeters and in 2 contiguous leads, meaning V1, V2, or 3 in AVF, or V5 and V6, 2 leads that are next to each other. It must be more than 2 millimeters in order to be enough. So that's where the 2 millimeters of ST elevation comes from. But if you see 1 millimeter of ST segment elevation and lateral T-wave inversion, or T-wave inversion in limb leads 1 or 2, either one, then you may be still looking at an injury current, even though it's less than 2 millimeters. You don't give that person TPA based upon that data, but you could admit them to the hospital, monitor them, check enzymes, and do a stress echo tomorrow. That'd be a perfectly reasonable way to pay attention to the ST segment elevation that's only 1 millimeter or so. Okay? So with that breakdown of the numbers, you can see that ST segment depression is a bad actor. You don't want to ever ignore that. And if we could quit there, it'd just be really swell. But there's a fly in the ointment. There is another cause of both ST elevation and ST depression. It is.
Hypertrophy.
No. Conduction defects. Okay? Let's just take this one. What are the 3 kinds of conduction defects? Right bottom branch block, left bottom branch block, and everything else, all the other NIVCDs. So basically what I'm saying is that when you have a conduction defect, you virtually always will have both T-wave axis changes and ST segment changes. You may have ST depression, you may have ST elevation, you may even have both. In fact, with a left bundle branch block, you almost always have both ST segment elevation and ST depression. Now, let's focus for a moment back on the ST elevation. Let's say that I gave you 100 EKGs of people who presented to the emergency room with chest pain, all of which happen to have ST elevation on their EKG. What percentage of those people are really having a bad event? Only 5%. So how do we begin to sort those out? Well, if we look at them, let's just pause the tape there in a minute. How do we sort those out? Well, if we had, again, 100 people with chest pain and all had ST elevation, 95% of those are going to be early repolarization, and 5% or so are going to be some bad actor. So how do you sort those out? Well, you use that very sensitive, overly sensitive T-wave axis. All right. Now let's say of those 100 EKGs, now I'm going to give you yet another rhetorical question. If I gave you 100 EKGs from people with chest pain, all of whom had ST segment elevation, but also all of whom had an abnormal T-wave axis, what percentage of those people would actually turn out to have had an MI when all the dust settles?
80 to 90%.
No, 5 to 10%. And you might say, well, wait a minute now. If you're going to use the T-wave axis to help you pick out those ST segment elevations that are not early repolarization, you're saying you're only going to get about 10 out of 100. That's right. Do you want to miss 10% of all the acute MIs that present? No. So my point is that when you see ST segment elevation and an abnormal T-wave axis, you're probably still all right. It's still probably early repolarization. It's just one of those other 29 things causing the T-wave axis to be abnormal, not ischemia and not an infarction. But don't ignore it. If you have ST elevation and an abnormal T-wave axis, put that person in, monitor them, check enzymes, serial EKGs, and make sure that they didn't have an MI, because about 5 or 10% of the time they will. Okay? So the T-wave axis idea is a great one and it works, but it really is still not very good. It's not very specific. It's overly sensitive. Is there another EKG change that if you see ST segment elevation and this other change, that 95% of the time it means the person's having an acute event?
Both elevation and ST depression.
Exactly. If you have an EKG with both ST segment elevation and the term is reciprocal ST depression. What do I mean by reciprocal? Well, let's look at the leads again. 1, 2, 3, R, L, F, V1, V2, V3, V4, V5, V6. 2, 3, and AVF is an inferior MI. V1, V2, V3, anterior MI. V5, V6, lateral MI. You see a triangle. If you have ST segment elevation here, look for reciprocal ST depression here or here. If you have ST segment elevation here, look for ST segment depression here and or here. Same way laterally. If you see ST elevation here and you have ST depression anteriorly or inferiorly, any of those, you take them. You don't go past go. You call the cath lab. You call the cardiologist. You take them straight and get them cath. So when you see ST segment elevation that is clustered in 1 or 2 or 3 leads, typically 2 or 3 leads in that pattern, with reciprocal ST depression, you're looking at an acute MI 95% of the time, with one exception. when you have a conduction defect. Now, I'm just browbeating y'all about this because you're going to miss it with the first 5 or 10 conduction defects that you see. You're going to be so focused on looking for the combination of ST elevation and ST depression that when you see it, you're going to think, oh, that's an acute MI. It'll be a bundle branch block. So the bundle branch block is one of those things that kind of masks or covers up or gives you the false illusion that the person's having an MI, when really the ST elevation and ST depression is due to the conduction defect and not an acute MI. Follow me so far? All right. Now, let's go at this from a slightly different angle. Let's put a timeline up. And we're going to say we'll put that as 0 time and we'll put this as 36 hours. And let's say 6 hours will be right along in here, and 3 hours long in there, 0 time. Okay. See the hand. Okay, we're going to get all the blood out of his hand. Now, his hand has no blood supply, does it? Is his hand, does any of the cells in his hand injured? No. Are they ischemic?
Yes.
Are they all ischemic or some of them ischemic?
Some of them.
They're all ischemic. They don't have any blood supply. And the longer that time passes, will you finally begin to get some cell death?
Yes.
How long? In other words, if I cut the blood supply off completely to his hand, it begins to get uncomfortable after a little while, doesn't it? So, how long is his hand ischemic before he begins to have some cells die? How many minutes?
No.
About 20 to 30 minutes. All right? And so starting at about 20, 25 minutes or so, you begin to have some of the cells in your hand die. How long does it take to have a completely ischemic blood supply? Until you have all the cells in his hand dead, or virtually all of them. About 3 hours. That is exactly how a myocardial infarction progresses. So think of the first 30 minutes as being ischemic. The first 3 hours as being critical. Every minute that passes, you are losing more cells. And so finally, at some point, typically at about 1 hour into this process, you go in with an angioplasty catheter and open that blood vessel back up. And you resupply blood to what kind of cells? Ischemic cells, and some of which have already died. So what happens to the heart? It doesn't work right for a while. It feels all tingly and doesn't contract nearly as well as it normally would. And so if you look at that process on this timeline, let's say at 0 time, how does a myocardial infarction occur anyway? Well, you have a plaque. Where's the plaque? It's between the intima and the media. In other words, you have this inner lining of the artery, kind of like a sheet of silk that is draped over the surface of this jagged plaque, and the other side of it against the media or the muscle layer of the heart. And one morning, typically about 4 or 5, 6 o'clock in the morning, that intima will tear. Now that plaque has been 60% stenosed for years. And yet, suddenly one morning, when that intima overlying the plaque tears, you suddenly begin to get platelet thrombi form on top of the place where the intima tore, where the plaque is exposed to the vascular blood supply. And over a period of about 20 to 30 minutes, what was a 60% stenosis becomes a 99-100% stenosis. And so during that first few minutes, say during the first 30 minutes or so, what happens? Nothing. You don't sense anything has happened. But what happens in the second 30 minutes? In other words, once you get that blood supply completely cut off, things start to change. You get uncomfortable. You wake up. You got this really tight, uncomfortable, full bursting sensation in the middle of your chest. And that is what?
Injury.
No, not yet. Remember the 30 minutes. We've cut the blood supply off, and we're now in that first 30 minutes. You got ischemia. What kind of ST segment changes does ischemia cause?
Depression.
All right, so let's take a typical acute inferior MI, and let's just pick one of the inferior leads, 2, 3, and AVF. Let's pick AVF. What would AVF look like during that first 30 minutes after the blood supply got cut off? Yeah, it looked like this. Okay, that's the baseline. You got that much ST segment depression. All right, now let's follow our timeline on that one. First 30 minutes, second 30 minutes. Right along in here, you start to get really uncomfortable, and you say, you better call 911. And over the next 15 or 20 minutes, you show up in the ER, and you run an EKG. That's what you should see. Okay? But what if you ran the EKG? What if the ambulance had a flat tire? And you ran the EKG right here. Well, something weird happens here. We said that ST segment depression is the hallmark of myocardial ischemia. But we also said that ST segment elevation is the hallmark of myocardial injury. Well, once you start to injure the heart muscle, you're going to go from ischemia to ST segment elevation in a very short period of time. So that you're going to go all the way from down here to up there in a matter of about 15 or 20 minutes, because you're rapidly shifting from ischemia to an injury current. When that occurs, if you happen to do the EKG in the ER right about the time you're in here, guess what kind of vector you get? Normal. The T-wave axis will be normal, and the ST segment vector will be normal. And so you can completely miss an acute MI in evolution during that few minutes window. And that is why we tell you to always, when you do an EKG on somebody having chest pain, if it looks okay, you come back in a few minutes and do it again. Because typically, if this is occurring in a matter of just 10 to 20 minutes, it'll dramatically change. You do the second EKG, and then it's obvious what's going on. Then you go to the cath lab. Otherwise, you let that time pass, and you get way out here on the curve. You get to that 3-hour window, most of those heart cells are already dead, and intervening and revascularizing the heart at that point doesn't do any good. So the EKG, not the cardiac enzymes, becomes your only mechanism of really picking up an acute MI early on in its course. And so if you're going to cath somebody, you need to know what you're looking for. So if we see the combination of ST segment elevation, and then I'm just telling you, no, wait a minute, this ST segment depression went away. when the ST segment elevation occurred. Now, how do you get them both on the same EKG?
Depending on what the lead.
They occur in this reciprocal pattern. In other words, as this inferior lead, if this is an acute inferior MI, as that inferior ischemia goes away and ST segment elevation begins, in other places, where if we're looking at an acute inferior MI with ST segment elevation now in 2-3 and AVF, where will the reciprocal changes of ST segment depression begin to show up? V1, V2, or V5 and V6. Typically V5 and V6, but could be either. But that's where you look for it. So it's almost like a mirror image when you have the ST segment depression indicating ischemia early on in a myocardial infarction. When you see it start to go away and ST segment elevation begin, then during that period of time, during that same period of time, you'll see the reciprocal ST depression start to develop. And so that the timing of the EKG becomes very important then. And so over time, you should see these what we call evolutionary changes of the EKG. But it's still basically ST segment elevation and ST segment depression. So to summarize that, if I told you that you had ST segment elevation on an EKG, what two questions would you want an answer to?
Is there reciprocal?
Are there reciprocal ST depressions?
And is there T-wave?
Are there any T-wave axis changes? If you've got either of those, then you should admit the patient, get enzymes, go on with the workup. Certainly, if you've got T-wave axis changes. If you've got ST elevation and ST depression and no conduction defect, they go to the cath lab. Okay? So, that stack of EKGs that I told you got, all of whom had ST segment elevation reflected on them. The way you pick out that 5% that's got something bad going on is by looking at the T-wave axis and by looking for reciprocal ST depression in the absence of a conduction defect. Does that make sense? Let's quit. Y'all look glazed over.
Lazy yellow moon coming up tonight, shining through the trees. Crickets are singing and lightning bugs are floating on the breeze. Baby, get ready. Across the field where the creek turns back by the old stumble road, I'm gonna take you to a special place that nobody knows. Baby, get ready.